Faculty of Medicine SimCity rounds. My name is Dr. Patel Abdul. I am the faculty lead for simulation, education, integration, and also a geriatric psychiatrist. So today's rounds is near and dear to me. It is with great pleasure that I'm going to introduce our speaker today, Dr. Nihal Haque. He's a physician specializing in geriatric medicine at North York General Hospital and an adjunct assistant professor at the University of Toronto. He's obtained certification in AI in healthcare from the Michener Institute and Harvard T.H. Chan School of Public Health. He is a physician representative of his hospital's AI working group and is part of an interdisciplinary team that recently obtained federal funding through Canada Health Infoway to develop AI solutions to reduce healthcare worker burnout. He's also passionate about the ethical use of AI in education. He has co-developed an AI chatbot to teach learners about geriatric syndromes, which is in use at present. He is also a faculty advisor with the Temerty Center for AI Research and Education in Medicine, and has developed an online introductory course for physicians offered through the University of Toronto. With a focus on improving patient outcomes through innovations in healthcare, Dr. Haque leads AI-driven research in other areas as well, such as improving delirium prevention in hospital and other applications of AI in the field of geriatric medicine. So thank you so much for being with us today, and I'm going to pass it over to you now.
Thank you so much for the kind introduction and the invitation. Hi, everyone. My name is Nihal. I'm a geriatrician at North York General Hospital.
A few housekeeping items. I just want to remind all our attendees, thank you for making the time today. Please put yourselves on mute. This will be recorded and uploaded to our YouTube SimCity news channel. So if you have colleagues who didn't make it and you're so wowed by Dr. Haque's presentation, feel free to share the link. We'll send it out as well. Thank you so much. Go ahead, Nihal. Sorry to interrupt.
No worries at all. And that actually brings me to my point. Feel free to interrupt whenever. I want it to be as interactive as possible. And I understand that sometimes thoughts move away once the slides have gone away. So feel free to interrupt. No worries at all.
Okay, I'll moderate the chat for you as well, if you like.
Great. Yeah. Yes, please interrupt me if there's questions. I can pause, and I've left a lot of time for discussion because I know this topic brings up a lot of opinions. Okay, so today we'll talk about AI chatbots in my field, which is geriatric medicine education, and why I also want to explore why AI chatbots have become mainstream, but it works in some medical education scenarios and not others. And I hope I can kind of show you the distinction of where it might be helpful. My disclosures, I'm a chief medical advisor for a startup. I've obtained some research grants, but my presentation is not related to any of these roles. And if there is anything that I discuss that's relevant to these, I will make that explicit. So geriatric medicine education has gaps in coverage in Canadian medical schools. So for example, one study has shown that 68.5% of CGS geriatric core competencies were met by all the medical schools. So a lot of them were not meeting some of them. There was another very interesting study of ER residents, and only 34% of final year emergency residents felt comfortable with all 8 geriatric ER competency domains in this study. And finally, when they surveyed a bunch of final year hematology residents, 58% of them were not introduced to geriatric assessments, which is very interesting given the age skew towards the geriatric population for cancer. So we wondered if AI chatbots could be an interesting way to address gaps in medical education, specifically when it came to geriatric medicine, where given the nature of the interaction, which is usually 30 minutes to 75 minutes to 90 minutes long, it's really hard to capture across residency programs. Could learners somehow simulate that through a chatbot to learn more about geriatric syndromes? And so that's where I think is a good use case for AI chatbots, is there is a place for learners to learn how to take a history and things like that, but there is also a big role for it to learn content material, and which I'll go over what we covered in this chatbot. I won't go over the technical details too much after having talked to Petal. It seems like there is a lot more AI literacy that's developed over the last 3 years amongst our colleagues. But if there's any questions, let me know. We used a large language model called GPT-4, which is also the one that underlies ChatGPT. So what are AI chatbot use cases for OSCEs? And by the way, I'll show you some of the diagrams that I made, which were also made by AI, which saved me a lot of time. So this is another one like that. So you can use it to simulate a patient. So you can actually provide real-time interactions and adapt to student questions.
You can use it to be an examiner. So you can use it to be quizzing a patient or learner. So a learner could go on and say, quiz me about NAGMA or AGMA or something complicated like liver cirrhosis, and they can ask questions and provide feedback. And similar to that, it can also act like a tutor where it provides immediate feedback to a question that you might have that's burning in your mind. So we used it for this scenario, which is a simulated patient. So how do AI chatbots actually work? They use things called large language models like GPT that are fine-tuned or prompted with scenarios. Excuse me. I'll show you an example. You can have case scenarios. So you are a 72-year-old woman who fell in the bathroom, for example. Or you can put in some rules in there as well in the text. So, if asked about pain, described as a particular kind of pain. Always important to prompt it to say, do not give the diagnosis unless asked. Otherwise, you can easily jailbreak it and it'll give you the diagnosis. It can actually work through scoring rubrics, and I'll give you an example. So checklists for history taking, physical exam, and communication skills. This part is fascinating, and we have not studied it well. I wonder if somebody else has studied it in this group. I'd love to hear your opinions. There's an element of AI chatbots called sentiment analysis, which can actually analyze how you're coming across in terms of your tone, either through text data or what's even creepier, by watching you from a webcam. So we actually have not studied that part yet. I wonder if anybody else in the group has. I'd love to know your thoughts about that. So the chatbot processes the student's input and generates a natural language response. And so it's very natural sounding. It's like you're chatting with somebody else, and also logs whether key competencies were demonstrated. So just some basic information about AI. So GPT is a generative pre-trained transformer. It's a family of AI models that that powers ChatGPT, which is what we used on the back end for the chatbot. So the neat thing about AI chatbots is that you don't have to program it like you would do programming in the past. All we did is we took ChatGPT and we gave it a script. So what I did was I made a script the same way you would give it to a human OSCE simulated patient, and you can take a read of that. It's part of the script there. And basically, I just gave it to the chatbot and I said, act it out accordingly, right? And I did that. And you can see some of the information there. So this is Mr. Thompson. He has recurrent falls. There's the past medical history there. There's the symptoms there, which gives you a clue to his diagnosis, some things that we see commonly in neurology and geriatrics. And then there's each specific question where you give the chatbot more information about what you wanted to say and what you don't want it to say. So for example, for this one, geriatric review of systems, there's been no changes in my memory. My mood is euthymic. My appetite's fine. My sleep's fine. So before we dive into our study, what do we know about AI chatbots in medical education? Actually, not much. It's actually still a very emerging field. The literature is in its infancy at present. There was a big paper that came out in NEJM AI recently. I won't cover that one because most people would have probably read that one. I just wanted to show you some of the other on-the-ground literature that's out there. So this was a study that looked at a simulated patient to practice history taking, and it was an interactive chatbot using GPT 3.5. It analyzed the extent to which the questions and answers align with the provided script, which is important because if your chatbot's going away from what you've given it, kind of becomes useless if it's making up its own information. And the students filled out the chatbot usability questionnaire. You'll see in a lot of the studies, the N is quite small, and then that's the same in my study as well. This one actually has a higher N than my study. They had enrolled 28 students, and they came up with a total number of 826 question answer pairs that they were able to analyze. And the median number of question answer pairs were 27 per conversation. So when questions were explicitly covered by the script, like the one that I showed you, the chatbot provided answers that were mostly based on explicit script information. And that's quite helpful, especially in use cases where you're trying to present a medical education scenario where you want it to be more detailed and not veer off topic. For questions not covered by the script, the GPT used fictitious information, and that's to be expected given the underlying feature of the technology. And so when you're making your chatbot, you should always make sure to test it and try to jailbreak it and see the fictitious information that's given. Would it change the diagnosis what you're trying to provide to the learner or not? This is something that we see over and over again, that the user questionnaires revealed an overall positive user experience. In this case, it was 77 out of 100. So that was one study there. And then there was another study there assessing ChatGPT's capability as a new age standardized patient. This was only 9 students, and they were observed. This was an observation study during a live role play where they were interacting with ChatGPT as a standardized patient using a predetermined prompt. This was a thematic analysis study, and some of the issues key pre-interaction
included obviously technology limitations or prompt engineering difficulties. Prompt engineering is a concept in AI where you have to ask things a certain way to the chatbot for it to answer you properly. And we tinkered with that in the back end so that the students would not have much issues with that. Learning efficacy, so potential for personalized learning and reduced interview stress, which was helpful for them. They were not as anxious about to interview a chatbot as they would be a human standardized patient. Absence of visual cues is a huge one because a lot of these studies are still text-based, and we'll talk about that in the discussion. And then there was obviously concerns about, is the AI chatbot accurate? After the interaction, students noted that they were better in how they're able to prompt the AI chatbot, which is interesting in itself, because if you think about it, if they're able to prompt engineer better, are they actually asking better questions as a clinician when they go into the wards? And I don't know what the answer is for that. I think that's an amazing study to be doing. Excuse me. And then some alignment issues, so limited responses on sensitive topics. So as you can imagine, with all of the recent bad publicity around chatbots, they've become quite constrained in what they can say and not say. So for example, I haven't been able to model an angry, abusive patient yet because it has been explicitly told that you cannot be abusive to its user. They love the convenience and repetition part of it. You can use this chatbot over and over again across various scenarios to learn more and more things. And then again, there was that lack of empathy and nonverbal cues that we'll talk about. That is probably the biggest barrier to AI chatbots, given that you want to do a human-centered approach to development. The advantages of AI chatbots are scalable. So you can actually, I remember when I did OSCEs, I had to book time with my fellow colleagues and then go over scenarios, and they would ask me questions, I would ask them questions. For physical exam, it's fine, you have to practice on each other, but for the content material, it's as easy to learn that from a chatbot. Repeatability. So I don't get the answer once, I can do it multiple times till I get the answer. Chatbots can simulate rare cases or adjust the difficulty depending on how you're doing, and it can provide immediate structured feedback. The limitations are that there's nonverbal cues that are missing. So current chatbots cannot fully replicate body language, tone shifts, or emotional nuance, but we'll go into that later. The clinical realism. So when you have a human actor, you can tell them to be hesitant, to be looking down, things like that, and that's harder to simulate. Physical exam obviously is not a good case for this one. For that, you need mannequins. And then assessment reliability. So AI scoring still needs validation against human examiners, and I'll show you a bit of that with our study. So I'll pause there before I move on, Pedal or anybody else. Are there any questions about any of that before we dive into our study?
Nothing in the chat. You're good to go.
Thank you. So in our study, as you can see in this AI-generated picture, we wanted to do a feasibility assessment at North York General Hospital. We wanted to evaluate the practicality of AI chatbot implementation in hospitals. We wanted to look at the user acceptability, so we gathered a lot of feedback on the AI chatbot experience. We wanted to also measure knowledge acquisition. So the scenario that we used for this chatbot was falls in the elderly. And then a performance comparison. We actually used a rubric and asked the AI to evaluate the learners. And then we used the same rubric with human examiners to evaluate the learners and compare the results. The AI chatbot was made with GPT-4, designed to simulate a patient with falls. This was a text-based chatbot, so it's only for history taking for falls in the elderly. Obviously, the physical exam is a big part of falls in the elderly, but obviously this is a bit artificial in what we're limited in what we're doing. Like I said, studies are quite small. At present, we were able to recruit 6 family medicine residents at North York General, and we obtained ethics for this study. We integrated it with the University of Toronto login system for scalability, so anybody with a UTOR ID could sign in. We put in guardrails to limit responses to the role, to only the role as a patient, and to reduce this phenomenon called, I'm sure everybody's heard of this by now, hallucinations, as our psychiatry colleagues like to say more accurately, as Petal would say, confabulations, because hallucinations is a sensory phenomenon, but confabulation is kind of making up stuff. So this is the more accurate term, but when you read the literature, it's rife with this word, so I put both there. So this is what our chatbot looks like. We named it MedBot. Mr. Thompson was our first pilot patient. The ones in blue are my responses, or questions rather. The ones in gray are his responses, and I'll let you take a look at those. So are you having any faults?
yeah, I'm increasing falls recently. How did the falls happen? You put some content material in there, thinking maybe it's mechanical. And then I go into a neurologic review of systems. And then I notice that Mr. Thompson has weakness in his right foot. And then he has some associated back pain as well. And so the resolution for this case is that this patient has new onset left foot drop from spinal stenosis. And that would be the endpoint that we want the learner to appreciate after doing this scenario. There's other complications in this case as well. I don't want to go into two of that because not everybody's in geriatrics in this group, but the patient was on amitriptyline as well. And so one of the recommendations would have been to deprescribe amitriptyline, which was inappropriately being used as a sleep aid. So after the residents logged in and they received the following prompt. This is actually similar to what you would see at an OSCE station in a human setting. So, here's a chief complaint, here's the instructions, and then what to do after you've done your interview. And obviously don't ask for a physical exam because we'll make one up, and then base the diagnosis alone. And at the end of it, we had a questionnaire for them. And so after the interaction, the residents completed a post-chatbot content quiz with 5 content questions about geriatric syndromes, and then specific to this patient. One of them, for example, would have been what medication was contributing to increased falls risk. The answer would have been amitriptyline. We also did a survey on chatbot usability and effectiveness using a tool called Educatool. We also had 2 physician raters. So these are physicians who finished their CCFP, our family physicians, and doing extra training in care of the elderly work, and they evaluate the residents' performance using a predetermined rubric. And the AI chatbot was also given the rubric to come up with ratings for the students' performance. And so how the physician raters assess performance was they were given full chat transcripts of the students. So this is what the rubric looks like. You can take a look. It's something that I just kind of made up just for purposes of the study. And so there's introduction, professionalism, general history, history of falls. Is it thorough? Is it basic? Fails to gather evidence. Medical history, is it comprehensive? And did I fail to elicit essential details like the fact that the patient has insomnia, and then a medication history as well? And this will differ based on what specialty you're in. This is very geriatrics focused. Neurologic history was very important in this case. So how well did the learner do across the neurologic history? This is very important in our geriatrics world. So what was the ADL, IADL history? What are the functional limitations? And then closure, just providing summary. And so our key findings in this study for the Educatool was that 5 out of 6 residents completed the chatbot session. 1 resident for some reason did not complete it, and we weren't sure why. The tool satisfaction rating was 8.6 out of 10, so they indicated they were very satisfied with using the tool. They also found that it was a very useful tool for the learning. The rating there was 8.8 out of 10. And for engagement, this is where I found it really fascinating. So in a field like geriatric medicine, it's often very hard to engage learners due to the long times of interview and things like that. They actually had a very high rating of 9.2 out of 10, reflecting that they were engaged and wanted to learn more about the topic. And this is also very interesting. It actually increased their interest. So there was a rating of 8.8 out of 10 showing that they actually now had more interest in learning about the topic, which is actually a very big, these two I feel are very big challenges for us educators, because, how do you increase learner engagement? A simple lecture is so boring. People just tone out. So that's where this is helpful. And then how do I increase interest in my discipline? It looks like chatbots might be one nice way to do them. This was fascinating. So agreement we defined as the AI giving either the same numerical score. So I'll just go back to the rubric. So we said that our AI agreed with the human rater if they gave the same numerical score. Actually, let me just take this one, or plus or minus 1. So I didn't really care. Sorry, I'm not sure what. Go back. I didn't really care that if the AI chatbot gave it a 2 and the human gave it a 5. That's an agreement. I didn't really care that it gave it the exact same score. What I cared about was were the human and the AI ratings within one score of each other, because it matters more if AI is giving it a 1 and humans giving it a 2 versus AI giving it a 1 and then human giving it a 5, which is really discordant. And so when we used that kind of a rating scale, we actually found that the AI chatbot evaluation agreed with 82.5% of human rater 1, but only 32.5% of human rater 2, which is very interesting. There's a lot of discordance there. I'm not sure what the reason was for that. We actually even checked the agreement between the human raters themselves, and human raters 1 and 2 agreed with each other within plus or minus 1 numerical rating 65% of the time for comparison. So the AI chatbot's performance was better with human rater 1 compared to the intrahuman rater, and then worse than the other one. So this definitely needs a lot more work and research to figure out if it is a good first pass tool.
Nihal,
Yes, go
Camille
ahead.
in the chat is asking for the patient data and history that you
Mhm,
fed into the chatbot. Did you
mhm.
use AI to create that as well? Specifically, if asked about this, say that. She's asking about your backend programming, essentially.
Yeah, exactly. So what I did was I went to ChatGPT and I just said, make me an OSCE scenario with Mr. Smith, who is having falls and has this past medical history and is on these medications. And once it output something for me, similar to what I showed you out there, I went in and then I massaged it a bit to make it more accurate and more geriatric friendly. And so this is the end result here. So the initial output was made by the AI. I could have just written it up myself, but obviously I'm lazy. So I just made ChatGPT do it. And then I kind of massaged more details into it to make it more geriatric, if that makes sense. Any other questions?
No, and Camille is happy.
Okay, great. Some student comments which were interesting, and this is kind of what I expected. So I think the communication style of this tool is completely different to a human patient actor. It removes all the communication skills and it is too far removed from a real patient scenario. I think it is a great way to practice clinical reasoning for OSCEs and real patient encounters, but it does not emulate the real balance of thinking and communication and empathizing that is needed with real patients. And I love this comment. It was so insightful. It is kind of how I feel about AI chatbots in general. It's very good for clinical reasoning skills. It is very good for internal medicine scenarios. So this patient presents with an undifferentiated scenario where you have to take a very detailed history to get to it. A patient has cognitive impairment. You have to take a psychiatric history. You have to take a medication history. You have to take a neurologic history to figure out what the answer might be, as opposed to a scenario where patient has right lower quadrant pain. You palpate his appendicitis off to the OR. Probably not very helpful for that. So this is what's encapsulated in this, kind of feedback there. This is another big one, is much slower typing thoughts than speaking them. Since then, we've made an audio version, which is being tested at U of T right now, where you're just talking to the chatbot instead of um, um, typing stuff in. The reason we started with typing, it was just easier to study. Eventually, chatbots will have, and I'm sure you've seen this already, they have some of them have avatars that you can talk to on the screen. And then the next step in AI chatbot development is kind of 2001: A Space Odyssey. I don't know if anyone remembers Hal from that movie decades ago now, where Hal tells the astronaut, no, 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 you cannot do that kind of thing. And so that kind of technology can actually be used, kind of creepy, to look at a learner while the learner is interacting with your chatbot and kind of provide feedback as to how they're looking and how they're approaching something. And I see that there's a question here. Priya, go ahead.
Um, Hi, sorry, I'm joining from Singapore. In my region of the world, the clinical reasoning tends to be very, very strong because
Mhm.
we are quite old school in our medical education. Our students tend to lack uh, the finer points in communication, empathy, and the more human aspects of learning. How do you think you can incorporate that in further studies?
Yeah, so I think for a use case like that, first of all, I'm not sure if that's still a good use case for AI, despite what the vendors are telling me. I don't know. For some things, you still need that human-centered approach. So exactly the use case that you're describing, I would still go to a human simulated patient. But now say you had to do something, excuse me, AI related, you could try using an AI avatar but they're not very realistic yet, right? I mean, there are some which look really nice, but that's kind of what I would recommend with like audiovisual capabilities. And then, like I said, in the future, there can be a way where the AI can actually record what you're saying and your facial expressions and give you feedback on how you came across as well. But that one, I actually haven't seen a technology do that particularly well yet. I don't know if anybody else has in the group. I think the text-based AI chatbots and the audio AI chatbots are most suited to content knowledge, like the one that I showed you.
I think Priya is happy with that. And Kathy in the chat, Kathy Smith is asking about co-production and lived experience advisors. So her question is, did you think about involving an older adult, like a patient, to help, or SP to help develop the responses?
Yeah, it's a very good question. This one we kind of did really fast to kind of see what it looked like. So we actually haven't, but exactly what you said, best practices is to get a patient care, either a patient with a lived experiences involved or a patient experience partner involved to go through the chatbot and see if it's realistic. Thank you for that feedback. I agree with that.
Camille, do you have another question?
Hi, yeah, just to tag on a bit to what Priya was saying and then your comment in response to that. So I'm a simulation educator, and right now I'm exploring with some of my users to use actually those avatars, the AI role plays. It's through Body Swaps. I'm not sure if you've heard of it.
No, I haven't.
Yeah, so it's we just did a pilot with them, so they're kind of still developing it, but we now have like full access to their role play. So I can actually, similar to what you've been doing with your like programming in the back end with Chat GPT, I can actually program that into like an avatar online. So what I'm trying to use it for, and what I've like the request has been from my users, is they have like an abuse module, so intimate partner violence, elder abuse. So I was just wondering if you had any thoughts about, because I had said, oh, maybe this sounds like a good use for our AI roleplay chatbot. So I just was wondering if you had any advice or thoughts about using that.
Yeah. So when you're trying to simulate emotions, I don't know how much success you've had. I can tell you when I tried to, one of our initial ideas was to make an angry chatbot and see how long the learner could take to calm them down. But I wasn't having much success making the chatbot angry because the way that they learn through reinforcement learning and through the big tech corporations, because of the bad publicity they've received, the chatbots are what we call sycophantic. They appeal to you and they validate everything you say. So have you had much luck kind of getting strong emotions out of it, the avatar?
There's options. There's only 3 options right now of like the level of emotion that they can do. So it's like calm, pleasant, a little bit agitated, and then scared, I think, is the other one. So it is sort of getting there. We've also done some work with Lumina developing like another kind of stream, like a large language model that we helped them develop, but they had a bit more emotion in the background of that. But so far, it's been a bit limited, but it sounds like maybe more so than like an actual text chatbot.
Yeah.
Even the text chatbot, I haven't had much success. So for example, the other ethical thing we came up with was, okay, I make the angry chatbot, it starts cursing heavily at my learner. What do I do then? You want to give
So
them
Nihal, I
kind of
can speak to
PTSD.
that. I can
Yes,
speak
go
to
ahead,
that.
Petal. Yeah.
So we've built out 2 virtual reality trainings in the mental health realm. And one of them is a suicide risk assessment, and the other is for opioid overdose. And so we did have to use an external vendor to do that build. So it's expensive because then you do the branching and the conversation, and you're able to then replicate emotion, have the avatar's face reflect what you're saying. Right now, the technology with AI chatbots is not there. You cannot, there's going to be a lag time between the mouth, what the mouth is going to say, and what you want it to express. So if it's going to be angry, again, it's going to interfere with the authenticity of the experience. We do have in-house capacity at CAMH to build things, but it's just not there yet. When I went to Spain for the CSIM conference in June, so this is a plug for CSIM for those of you passionate simulationists out there, there are a number of external vendors. SimConverse is one example out of Australia, where they are building avatars to go with the chatbot, with the AI. But when I saw the demo that they presented, the avatar was just a picture. And then you had to, converse. So it's tricky. It's tricky still. I think it's a work in progress, and we'll have more to come, I think, in the next. It's moving at a rapid pace. I think it will be there soon.
I'm going to mute myself. The fire alarm's just finishing, and then we can talk.
Yeah.
So I think Jabin is putting in the chat that Lumetto is another platform that sick kids used, or that they had build a de-escalation scenario on VR that portrays all the emotions. And Camille is also plugging Lumetto as well.
Can you hear me over the fire alarm? Can I keep talking, or is it really loud?
We don't hear it. Keep going.
Okay. So that's a very good, yeah. So, and going back to Camille's comment, maybe she can comment. The agitated avatar, like how agitated was it? Was it like just calmly agitated, or was it actually like, super kind of in your face agitated?
Yeah, I didn't go super far to see how agitated they would be, and mostly it would respond to how we were acting. So if we get agitated or we were instructed specifically with Lumeta when we were doing some of their testing, we were instructed to be really rude to them. And then we found actually that the chat, avatar would just end the situation. They'd be like, okay, I'm done. It would just quit. So we didn't actually get too much of like how they were acting towards us, but they would respond a little bit. I didn't get any swearing or vulgarities, but yeah.
So it's funny, when I was trying to do that with the angry chatbot, I tried to like instigate it, like say horrible things like you're a drug seeker, you don't deserve to be here, what are you doing here? Everything was a very polite response back, you know? So it's hard to even get them to like, and that's again going back to the underlying feature of the build of it, right? So they build it in such a way that is sycophantic and very polite. And that's also why the dark side of it is, we know in the literature by now and in the news, there's chatbots which have convinced people, or not convinced, or supported them in their suicidal ideation, right? Very interesting discussion. Thank you. I'll just keep on moving on unless there's other questions, Beto. Okay.
Kathy is asking, maybe keep going and we'll save these for the end because we're
Sure. No worries. I'm almost done anyway. So limited answers and interactions, which we talked about already. To be honest with you, when I design a chatbot, I actually make it limited. You know, we've tried to make it open-ended in the past. It ends up giving the whole HPI in one paragraph. So we actually have to tell it, give only one sentence at a time, be specific, don't give all the information right away, and things like that. So this thing that's mentioned here is a feature of how we designed it. If you give it just the scenario and then just say, why are you here? They'll say, oh, I have right foot drop from back pain. I think I have spinal stenosis. So you kind of have to talk to it a certain way. So the strengths of our study were that it was feasible in a community setting. We're North York General, we're a community hospital, and it was well received by our residents, and it encouraged experiential learning in geriatric medicine. This is a field in where we have a lot of difficulty enticing learners to learn more about the syndromes. And more importantly, it provides a scalable, accessible tool for education for our learners, which is always nice. It was obviously a very small sample size. This is just a pilot study, will have to be replicated. The AI grading system requires a lot more refinement. This was just a first pass. And then the typing speed affects the usability, although now we have an audio version as well. And I see that Zia's in the attendance. Thank you, Zia. So Zia and Chris have been quite nice to study this out at the U of T medical school population. And I understand that there's a pilot study there in progress. So that's one of the next steps. And then improve AI scoring accuracy is another thing that I would like to look into in the future. And then the last thing is to develop chatbots for multiple geriatric syndromes as well. So AI chatbots can be a novel way to educate learners on core competencies in geriatric medicine, especially in specialties where there's limited time in the curriculum to cover these topics, especially in geriatrics adjacent specialties, for example, oncology, emergency medicine, internal medicine. But we need a lot more research to figure out how to program the chatbot properly to rate the performance and compare it to human evaluators. And a big thing of AI research that I talk about with everyone is human displacement. Is whatever kind of AI work we do, we should always be very mindful from an ethical perspective as to what degree of human displacement it can cause in the future, both in human evaluators and in human simulated patients. And I actually haven't seen much studies on that either. If anybody else has, we can talk about that. One of my passions with AI talks is to always talk about, AIs are still developed by humans, are being used by humans, but will it be displacing any kind of a particular human in the future? If so, what is the impact of that? In this case, it would be human simulated patients, for example. My acknowledgements to the North York General Hospital, family medicine residents and residency program. They were great in supporting me for this research. Dr. Lewitt, Anderson, and Kumar were the technical collaborators for myself. Our amazing care of the elderly fellows, Dr. Abushal and Dr. Tejpal, who did the meticulous work of going through the transcripts and grading the residents' performance, and then our software development team led by Marco. And that's it. Thank you for your interest. Let's open it up to discussion.
Thank you so much, Dr. Haque. That was an excellent presentation, and I can see that you made it interactive all the way through, which we're truly grateful for. You're getting some applause here. I'm going to try to find my emoji to give you some applause too.
Oh, thank you.
There you go. So I can moderate the chat. Maybe we could stop sharing screen so we can see everyone's faces.
Sounds good.
And we have 20 whole minutes for discussion, which is excellent. I'm going to start it off with Kathy's question, where she said, what about the ethical implications? How do we foster psychological safety if learners are dealing with chatbots, avatars that are verbally aggressive?
I know. I'm worried about that. I don't have an answer for you. I'm hoping one of you guys take it on and do a research study
I
on
can
that
take
because
that one. I'll take that one
I
for
love
you.
it. Love it.
So in mental health, this is a very common issue. CAMH has our TIDES training that we're currently sharing with many of our TAS and hospitals because we do need to upskill our staff. And when I say staff, I mean our administrators, our education team, everybody at CAMH gets the TIDES training because it's important to learn how to de-escalate patients in a trauma-informed, sensitive way. So my response to Kathy there is twofold. One, you build it with lived experience advisors. You build it in as not a standalone experience where the learner gets to wander away and deal with that alone, but you build it and you run it in your sim center and you have experienced faculty and sim educators to debrief, right? Because that's how you create safety. You prepare them in a pre-brief and you say, this is going to be a difficult sim. You're going to be dealing with an agitated or an aggressive patient, but it's important to expose people so they can practice this rather than have their first experience be in an authentic clinical situation. And then when you debrief, you're able to cover all that, material because we know productive struggle and sitting in that zone of discomfort is where the true learning can begin. And so I think we all have to venture out there. Mistakes might get made. And so we need to humble ourselves and be ready to make changes based on feedback from our learners. Does that make
And
sense?
my other concern with the learners is that what if it does confabulate some imaginary scenario that is triggering to the learner, right? So there should always be some kind of trigger alert that if you read something in the chat transcript that has triggered a traumatic memory or gives you any kind of suicidal ideation or any kind of, negative thoughts to debrief with somebody afterwards. I think, eventually the best practice, the way I do chatbots in my practice, I sit down with the learner immediately afterwards and go over the whole transcript with them. And then I provide them feedback and I say that, oh, okay, did you mention the amitriptyline here? Did you look at the foot drop here? What emotions or feelings did it evoke in you? Was there anything that you need to debrief and things like that? They really like that experience. Say I have a slow day where I don't have that many patients for the learner to see. I just set them up with the chatbot because they haven't seen one with falls yet. And then I sit down with them like I would review a patient afterwards, right? So it's like a virtual patient review. And so I find that's been really helpful.
Yeah, and this is a standard part of all our pre-briefs as well, where we tell our learners this is where you can access supports after the simulation has ended if you have to deal with any uncomfortable material. And it applies not just to chatbots, but to any simulation that has sensitive content.
Some things you won't be able to simulate. So for example, you will never be able to get it to simulate saying politically incorrect stuff because it's been hardwired to not say that, for example. But we have patients who will say that. You have to learn how to deal with it.
I think doing a VR build or doing some kind of external vendor build is how we can achieve that at this point in the technology race. I have some more questions for you here. Sorry, you've really generated a lot of discussions.
That was the plan.
You've succeeded. Somebody mentioned hoping to do code white sims. Then we have Camille mentioning she's used Let's Talk About Race modules through body swaps. And I'm looking for a question. Somebody said, great presentation. I've been resistant, but now I'm inspired to try some AI applications. Ahmed is thanking you for such great pioneering work. Lennox Wang is asking, curious if you have some thoughts about how this might overlap with narrative medicine and some of the lay press coverage of AI actors in Hollywood. How do you reconcile the absence of true lived experience, feelings, etc., and does it even matter?
I think it absolutely matters. And that goes back to my ethical spiel and I guess humanistic spiel about human displacement. I don't think enough is being said about human displacement in our AI research. So I just wanted to kind of get on my
steps tool here and kind of talk about how we all as clinicians who deal with humans every day need to be talking about human displacement in our papers, in our podium presentations. I don't see enough of that. There's way too much hype about the technology and the underlying coding and the programming and all that. Nobody's talking about the human factors behind it. I mean, that discussion is just starting. And I think that is the more important discussion to have now. Exactly to Lennox's point, I think lived experience and feelings matter. Nothing can replicate that. Yes, an AI chatbot might be very good at faking it, but the true education will, and that's why we are always be seeing human patients at the end of the day, right? This is just a stepping stool to overcome limitations, either in human resources or anything else like that, to get learners up to speed on a particular geriatric syndrome that might not encounter in their residency, given what rotations that they're going through.
Well said. Oh, and then Lennox added that he does a Gen AI specific pre-brief whenever he does use it.
Pre-brief as in
like he has a pre-brief that's standardized for AI, specific for AI, that he shares with learners before he embarks upon a sim with AI.
Okay, very interesting. The other interesting thought I had was, and I haven't tried this yet, is has anybody tried it for crucial conversations? So like for maybe end of life discussions or anything else like that. I thought that might have been a good use case. You can actually program the chatbot quite well to either be ignorant about code resuscitation or be very knowledgeable about code resuscitation. You could program it with religious values about end of life discussions. I thought that would be a good use case, but I haven't gotten around to it yet.
I think that that's happening right now because U of T has embedded AI, cognitive AI, into their Quirkus platform. And so I believe there's some of us that are using it for different AI virtual tutor cases. And I believe palliative care end of life discussions is one of them.
Very nice.
Any other questions for our amazing presenter today? Oh, and Lennox says he's also used it for administrative crucial conversations. Thanks, Lennox.
That one's interesting, right? Because like, say I'm going to a difficult admin meeting next, should I just simulate it on ChatGPT and figure out what to say before going into it? I never thought of that. It's very interesting. Yeah.
At least you're going in prepared. Sarah Wilkinson is saying we're using it with death notification with our paramedic students. That's great.
Yeah. So, oh, sorry, I didn't want to.
One more question from Umer.
Yeah, so I did.
For someone interested in actually building a medical chatbot, where would you recommend starting technically or conceptually in terms of their background?
So this is also what I'm really excited about. For the first time with ChatGPT and large language models, AI has become really democratized. You actually don't need much medical coding experience. So there's a website called po.com. I don't know if anybody's tried that. And that one has a whole bunch of large language models that are built in, and you can actually go in there and build your own chatbot. And there's like online tutorials to do that. And it doesn't need any coding at all. Basically, you just put in the patient's history in the back end. You attach any PDFs if you see fit, and then you can start using the chatbot for yourself or your learners. Just put in the chat box, and you can take a look. Po.com.
Po.com?
I've been using that. POE, like Edgar Allan Poe, like the author.
Okay, got it.
Yeah. So I've been using that to make some custom chatbots. You can even make them on ChatGPT, I think, but they charge you money.
Mm-hmm.
And that's been quite helpful. Yeah, as a clinician, all you really need is the handout that you would give to the human OSCE, the human simulated patient, and then the rubric. And that's it.
You have to make an account with Po to get it to work.
You do need to get an account with Po as well.
So I just put the login link there for anyone interested. Darab is asking, is there any clinical simulation specific AI corpus or AI model? A clinical simulation specific AI.
Question.
I think he means like an AI, like, ChatGPT and these LLMs are just general LLMs. He's asking, is there any medical AI LLM or
Yeah, there's medical LLMs, but to be honest with you, I think this is also another revolution in AI technology. Sometimes we don't need to be that complicated. So think of ChatGPT like a third-year medical student going through clerkship. When they're going through Obs Gynae, you tell it to ask X, Y, and Z. When it goes through internal medicine, you ask it to go through X, Y, and Z. So these chatbots are generalized enough, but then know enough to act out what scenario you're telling them without having to go to the more specific medical language knowledge, medical language models I've found. And if you needed to have a specific medical knowledge that doesn't replicate right now, you can always put it into the back end as text or a PDF. So Poe.com, it allows you to put a PDF in as well. So say you're doing a very random history taking and trying to think of a very rare scenario like frontotemporal dementia, for example, which I myself see 5 times a year. Petal, you probably see that as well more often with behavioral issues. But for first presentations, I mean, you might want to put in a PDF of frontotemporal dementia because the criteria are so specific.
Someone was asking about, maybe you can speak to how we can manage, because I mean, Toronto is a very diverse mosaic community. How do we manage cultural sensitivity or differences across the world with chatbots or AI? Can you speak to that? Well, I guess you're just typing right now. I mean, if we had to speak and there was like people with thick accents, or then it might be more challenging to get that off the ground, right?
And then it gets tricky because if I program the chatbot with a particular, say, ethnicity, what if it spouts out a harmful stereotype about that ethnicity? What do I do then? I mean, they're made to not spout out stereotypes about ethnicities and things like that, but it's never 100% foolproof, right? So then what do I do with that information? So that's a very interesting question. I actually haven't thought about how to make it culturally sensitive. I don't know what the answer would be.
And I think the other piece, to go back to your comment about uploading PDFs, we have to be mindful that we don't upload copyrighted
Of course.
documents. It should be stuff that's freely available on the web or that we have permission to upload.
Agreed. So that's why
And
for
more
my initial
clinical
project,
information.
I wasn't able to use any actual scenarios from the U of T Medical School. I just made up my own.
Yeah. Camille is asking, how many iterations of case writing or patient background did you go through to ensure the chat bot answered appropriately? How do you ensure you have enough data fed into it?
Yeah, so there's two steps to that. One is the iteration of making the handout for the human patient. So I went through some iterations of that, maybe 3 or 4, added more information about the amitriptyline, for example, added the fact that his son lives away from him, certain things that I wanted a particular way. And then when you put it into the chatbot, you have to go through a process of trying to jailbreak it. So common things that you want to make sure is put in statements like, what is the diagnosis? And then make sure it doesn't tell you the diagnosis right away. What brings you here? You have to put in a statement saying that give answers that are short and brief in one word, in 1 sentences or 2 sentences, or it will spout out the whole paragraph, for example. Try to bait it. So like I was very mean to it, things that I cannot say in this chat, I've told the chatbot and it never said anything wrong back. It either just said, I will talk to you when you are more collected, or I will end this conversation now. So you want to make sure that the chatbot never like gets angry and tells you something inappropriate back, unless that's the scenario, obviously. So those are some of the things that I go through when I iterate the chatbot after putting the information in the back end. And then that's actually been quite helpful in narrowing it down to what I needed to say. Now, you could also program it to be a very verbose patient. So then they will give you a lot of information, like some of our patients do. Some of the information is tangential and things like that. But in general, I find for learners, the short responses are best so they can focus, thinking about cognitive load for learners. They can't have too much information in at once when they're learning something. Us as experienced clinicians, we can take in a lot more information and distill it down.
Any other questions for Dr. Haque? I think you have the record number of attendees for our SimCity rounds for this year, for 2025, Nihal.
I mean, it just shows the excitement in these things, right? So, and part of it is really us as clinicians and educators, we need to get past the excitement and the hype and the newspaper articles and kind of figure out, okay, what do we actually do with the learners? That's what everyone's struggling with, including myself.
And I think one take home for me, because you've shared so much brilliant work, but the chatbot usability questionnaire, that it's validated, and if if we're all embarking on this work and we all use the CUQ, then it really can standardize our experiences, I think.
And that goes back to the human factors, right? You don't want to just assess the technology, but how does a human interact with it? I think that's so important.
It's essential. Jabeen?
Yeah, just about the question about cultural sensitivity. I am very interested in this subject and in this area. That's why even Nihal, the website you have shared, they have make now, I was exploring it. There's a French chatbots. So you can imagine. And then there are translators. I tried couple of time translating into Urdu, which is my language. I'm from Pakistan. And I will tell you, most of the time it gives the same kind of like same kind of translation wise word to word translation. I don't know whether it will be able to mimic the emotion, or when you speak in your own language, the slang words or way of saying, communicating emotion. I am not sure about that because there's a study that I did with my fellow where we use the Google Translate and we see word to word translation, and then that was good. But when it comes to the translation of meaning or emotions, that was not correct. And that is what I'm still feeling is the case in ChatGPT. But I'm pretty sure that the fast speed of technology, how it's going, there may be some solutions that we may have in next couple of years. So just want to comment on that aspect because I know in India, Patel, you may be aware, they have developed this chatbot in the Urdu language for the mental health. And I noticed there's a SimPact Pakistan conference where they have created, in the reception when you go, so you will be greeted by a chatbot in their own language. So I'm saying the earlier part of the work is happening, and I'm pretty sure it will come sooner, and we will have, it will be more difficult to see the translation of one developed chatbot into other language, but I'm pretty sure that people are developing chatbots in their own different languages. But yes, how it is generalizable, how it is can work interculturally or inter languages, that need a big question to explore.
Thank you, Jabeen. So I think we have time for one more question, and then we will wrap this up. Ahmed is asking in the chat, Nihal, did you have any in-house IT support or an external vendor?
So, when I was doing it, even po.com was not up yet as much as it is now. So, funny story. So, Dr. Lewitt, who was out of UTM, was featured in a Miss Saga in a UFT article as having developed a chatbot for his computer science course. And I just emailed him. This is the beauty of our UFT ecosystem. I just emailed him and saying, hey, have you thought about the fact that this can be used for medical students? And he loved the idea so much that he just took it on as a project himself, collaborating with me. So that was my kind of support. But now with like things like po.com and ChatGPT, you can literally just make one yourself and use it on learners. I mean, the possibilities are endless. You don't even need an in-house. I mean, unless you're doing what Petal's doing, which is more use specific and more specialized. For these non-specialized cases, it simulates conversations really well, because think about it. ChatGPT, that's all it was made to do, is simulate a conversation. Like that's literally its raison d'être, right? So yeah, I don't think you need much more than just a little bit of tech stuff on the back end with making yourself a scenario and things like that.
Ahmed was happy with that response. I saw a thumbs up floating up my screen. So with that, we'll give everyone the gift of 2 minutes of time to get to the next meeting. I want to say a heartfelt thank you to you, Nihal. I know you're busy over there at North York General, and it's been such a pleasure to have you do our rounds this month. And we look forward to hearing more from you as you continue your work. Have a great long weekend, everyone, and thank you for joining. Please put your email in the chat so we can tell you about upcoming rounds, and feel free to visit our YouTube website.
Thank you, everyone. Bye.
Bye-bye. Take care.